So we're going to talk about bisphosphonates. And the first thing to say is that these molecules have been known since the 1800s. They're small molecules. They're pyrophosphate analogs. Pyrophosphate is that structure on the top. And pyrophosphate we make, some metabolic product. The real breakthrough in the development of this class was to put a carbon atom between the two phosphates. Now, what happens when you put a carbon atom is that you render these molecules stable. They are not metabolized. The body, the human body, and no organism except, I think, a unicellular algae in the Pacific has a means to break that PCP bond. So they're stable, they have great affinity for bone, and their pharmacokinetics, maybe Serge talked about this, are such that they are excreted unchanged in the urine. Okay? So in effect, they could theoretically last forever if they don't ever leave bone. But they do leave bone. But there are several half-lives of these drugs. One half-life is what goes to bone, and what doesn't gets excreted unchanged. And then there's a much slower half-life, and that's a function of some of these other substituents. Some of these molecules, like zoledronic acid, sticks to bone forever. That's why we give it once a year. And others have a shorter half-life, but they all have relatively long half-lives. Now, let me introduce you on the left to the original bisphosphonates. They used to be called diphosphonates. And clodronate, which is still used in some parts of the world. Mohammed, do you still use it in Canada? Clodronate?
Not anymore.
But you used to have it.
Yes, he told us that it was there, but...
Not anymore? Okay, but for years it was available. In this country, clodronate has never been available. Etidronate is one of the original bisphosphonates. Dr. Cyrus may have talked to you about etidronate, didronel, the original drug for Paget's disease. It was developed and approved, and these drugs are of historical interest because the drugs on the right have proved themselves to be much more useful. And the difference between the drugs on the left and the drugs on the right have to do with the amino substitution. Every one of these drugs, pamidronate, alendronate, zoledronic acid, and risedronate, have an amino substitution or two nitrogen atoms. And that changes the properties of these bisphosphonates to being extremely potent, much more potent than the non-substituted bisphosphonates. Now, they also work in different ways. On the left, those molecules, being the way they are, kind of intercalate themselves into the ATP molecule. The AMP, that POP bond of ATP, is easily cleaved. And in terms of that exchange reaction, this PCP gets globbed onto an ATP-type molecule, which has no energy, doesn't get metabolized energy. So it basically starves the cell by being an ATP analog as it gets into ATP. These drugs on the right work completely differently. Now, let me give you a little historical point. I think history is always important when you think about some things. 1969, this article was published in Science, and it had to do with these diphosphonates, okay, the ones on the left, inhibit hydroxyproline dissolution in vitro and bone resorption in tissue culture. That was the title of this Science article. And the three guys up top here, Graham Russell is still very active, one of the major figures in our field. He is in England, and he was a very young man then. Herbie Fleisch in the middle, passed away a few years ago, was a giant in this field. And Dave Francis used to work for Procter & Gamble as a scientist. When Procter & Gamble was interested, Procter & Gamble actually developed didronel, etidronate, and risedronate, believe it or not. Okay, so those are the three guys. And in this article, here's what they said. Tucked in, their potential therapeutic effect in this respect. Since diphosphonates appear to be relatively non-toxic, they might prove valuable in the treatment of osteoporosis and other human diseases that involve increased resorption of bone. Kind of one of those prophetic comments. No one had even thought of that before. And that was the first idea, that these bisphosphonates might be useful. The amino-substituted bisphosphonates work by inhibiting the mevalonic acid pathway. And all of you know this pathway because this is the pathway that is influenced by the statins. So this first step in the in the synthesis of cholesterol is inhibited by the statins. And if you then move this down this pathway a little bit further, you find the enzyme or enzymes that are inhibited by the bisphosphonates. And the one on the bottom is the big one, farnesyl synthase. And this pyrophosphate intermediate is inhibited specifically by the amino-substituted bisphosphonates. They also may affect areas in several other steps, but farnesyl pyrophosphate synthase is the key enzyme that is inhibited by these bisphosphonates. Now, what they do as a result is block the generation of these, called these geranylated proteins that are very important for membrane trafficking of the osteocyte. And if you inhibit these anchoring proteins, you basically disrupt the membrane structure. And the osteoclast doesn't do very well. It becomes dysfunctional, and actually the cell will die. These bisphosphonates can actually be cidal to the osteoclast. Now, you may ask the question, and it's a reasonable one, if this is true, if it's the same pathway shared by the statins and the bisphosphonates, would the bisphosphonates lower your cholesterol level? Seems reasonable, but it doesn't. On the other hand, you may think that the bisphosphonates would reduce the cholesterol and the statins would inhibit osteoclast. So you have a crosstalk here. Why don't the statins improve bone, and why don't the bisphosphonates reduce the cholesterol? I mean, can you imagine if you had such a drug? You could go home and collect your Nobel Prize. So it all has to do with tissue specificity. So if the statins had affinity for bone, yeah, they would probably be very good drugs. And if the bisphosphonates had affinity for liver, probably be pretty good drugs to reduce the cholesterol. But that's not the case. So that's why we have two classes of drugs affecting the same pathway, but having very different effects. So the central mechanism of action of the bisphosphonates is the inhibition of bone resorption and by impairing the osteoclast. So this is an osteoclast. Did David show you a picture of osteoclast? He has beautiful pictures of osteoclast. This is a stylized view of an osteoclast, a multinucleated giant cell. And it's on the surface of bone in areas where there's active bone turnover. And of course, as I told you last week, this is the prime mover of the bone remodeling system. And as the osteoclast pumps out hydrogen atoms and also cathepsin K and other molecules that are important for the excavation of this micro unit of bone, in the presence of the bisphosphonates, which have affinity for bone mineral, they go right onto bone mineral, and there's an osteoclast. They're phagocytes, the osteoclast. So it eats or engulfs the drug, the bisphosphonate. And as a result of the intracellular accumulation of the bisphosphonates, it affects the cellular pathway I mentioned, and this osteoclast doesn't do very well. And so here is the way it works. The bisphosphonates on the left, they literally bind to bone mineral. They're taken up in the top panel by the osteoclast, and then there's a little bit of a release and uptake. There is a metabolism, particularly if the osteoclast dies, but there is a little bit of a release, but they're still there. So there's a little bit of an intracellular turnover. So they can be reused, recycled as it were, and hit another osteoclast. And as a result, bone resorption is inhibited. So here are the 4 bisphosphonates that we are going to talk about. These are all, of course, the generics. You know, they're all generic, by the way. They're all available as generics in the United States. So alendronate, just for those of you who may not know, but I'm sure you all know, is Fosamax. Ibandronate is Boniva, or in some parts of the world, Bonviva. Resedronate is Actonel, and zoledronic acid in the context of the treatment for osteoporosis is called Reclast. And they're all amino-substituted. You can see they're a little bit different in terms of their configuration, and they have different properties. But in effect, we're not going to discuss this too much. They all have similar actions. In terms of alendronate, that was the original bisphosphonate that was developed. It was developed with some interesting insight by Gideon Rodin, who was one of the giants in our field. Gideon was at the University of Connecticut, and he was recruited to Merck. And around the time, that would have been in the early 1990s, when Merck had made a commitment to develop a bone-active drug. And Gideon had a choice of hundreds of bisphosphonates, and this particular molecule was in the house of an Italian drug company. Gideon, for reasons that have to do with his brilliance, said, we want to develop this one. So he picked this one. And this is sort of historically the first drug to be approved in 1995, the first bisphosphonate. And here's from the FIT trial, which is one of the important phase 3 trials that established the efficacy of alendronate. They all, as I mentioned on Monday, they all inhibit vertebral fractures, but this data also suggests that the drug inhibits hip fractures and the drug inhibits forearm fractures. So it meets that criterion I mentioned before. It has a broad spectrum, vertebral, non-vertebral, and specifically hip fracture efficacy. Curiously, again, I think it is curious, the hip fracture story is fascinating. There were 22 hip fractures in the placebo arm, and there were 11 hip fractures in the drug arm. And look at the p-value. If there was one off, if there were one fewer hip fractures in the placebo or one more hip fracture in the drug arm, it would have not been significant. A matter of one either way would have changed the way we think about alendronate. But here are the data. Reduces hip fracture. And now to quickly move on, because I'm not going to talk about all of these in great detail, but make more comments about zoledronic acid than the others. Here's the resedronate data. That's the second bisphosphonate to be developed about 3 or 4 years later. It also reduces vertebral fractures. And as you can see, in terms of hip fracture, both in terms of a low bone density group as defined, or on the right, a low bone density group with a prevalent vertebral fracture, you can see in both cases there is a significant reduction in hip fracture. The story with ibandronate is not quite so straightforward. The original phase 3 trial, known as BONE, and it was a complicated trial. We'll go into the details. One was a daily administration. One was a intermittent daily and then no treatment for a while. Doesn't matter. Against placebo. You can see that there was no effect in terms of non-vertebral fractures, and there wasn't any effect on hip fracture. So the original intention to treat trial with this as an endpoint did not show an effect. So in the package insert for ibandronate, there is not an indication for hip fracture or non-vertebral fracture because of these data. There was a post hoc analysis, though, that looked at whether or not this drug did affect non-vertebral fractures as a function of the T-score of the femoral neck. T-score of the femoral neck is pretty important. And in this case, they showed in a post hoc analysis, this was not planned. If you looked at the group that had a T-score of less than -3, and looking at the daily dosing, there was a significant reduction in non-vertebral fractures. Okay? So that's where we are with ibandronate. And there are people who said, well, you know, they're all the same. These drugs, you know, you can't tease out differences that much. And yeah, the phase 3 trial didn't show an effect. But remember, alendronate only showed an effect by the skin of its teeth. And so they're all the same. On the other hand, to be real rigorous, no. You have to say that there is no clear evidence, except the post hoc study, that ibandronate reduces non-vertebral or hip fracture. Now, zoledronic acid. Did Felicia talk about zoledronic acid yesterday? Felicia loves zoledronic acid, and she refers to it as Zol, as her soulmate. Zol here, Zol there. She loves Zol. It's a good drug, and this is from a nice paper. The definitive trial that was published in the New England Journal of Medicine. A cast of characters. All these studies have cast of characters. And Dennis Black was the primary author. Dennis is one of the major data management people in our field. He has been, as is Steve Cummings, they have been involved in pretty much all the major clinical trials in our drugs since they were developed. They're at UCSF. Eunice, do you know, where's Eunice? Do you know these guys?
I know Dennis Black, but not Steve.
You don't know Steve? Well, Steve kind of has moved off target. He's at some other place. And
I think CPMC.
yeah, yeah. And he claims he's working for Google. I don't know what he's doing with Google, but Steve's an interesting man. But Dennis is still there. Okay. And actually, yeah, so Dennis is a good friend, and as is Steve. So here is the Horizon trial, the pivotal trial. And it was looking at the effect of intravenous zoledronic acid. This is the most potent of the bisphosphonates in terms of their affinity for bone mineral. And if you think about it, intravenous 5 milligrams infused over 15 to 30 minutes. We prefer 30 minutes. Just think about it as it's like a primer coat of paint. A molecular layer of drug is coating bone surface. Not necessarily active bone surface, just bone mineral. And so once you get this drug, your bones are coated with a molecular layer of zoledronic acid for about a year. And that was the study. 3 years, randomized, double-blind, placebo-controlled. Big study in our field, not in the cardiovascular field, but in our field. 7,700 patients is a big study. You can see how enormous this was in terms of scope. 27 countries, many, many clinical centers. There was, again, the usual endpoint being vertebral fractures after 3 years. There were two different strata, but we won't get into the different risk stratification. But there was also, within combining two subgroups by intention to treat, also a primary endpoint of hip fracture. And then the secondary endpoints were non-vert, clinical vert, bone density, biochemical markers, and a few other things. So here are one of the primary endpoints, morphometric. That means X-ray based vertebral fractures. And you can see that by 3 years for sure, but also after only 1 year, there is a significant reduction in the incidence of new vertebral fractures. And if you look at this in the Kaplan-Meier way, as the cumulative risk of clinical vert fractures or non-vert fractures, you can see in the orange, the curves separate, particularly clinical vertebral fractures, within about 6 months. Within 12 to 18 months, you see a difference between placebo and the drug in terms of non-vertebral fracture. And looking at hip fracture also is pretty good. 40% reduction in hip fracture. And again, these Kaplan-Meier curves, it's hard to do statistics to say exactly when these curves significantly differentiate from each other, but they clearly do. And you can see by the end, 3 years, there's a major difference between drug and placebo. Here are the bone density data. Total hip, femoral neck, lumbar spine. Pretty robust. Good to see an increase in bone density. There has been a lot of discussion about how useful this marker is. Does an increase in bone density necessarily say that there's going to be a reduction in fracture? In fact, Steve Cummings and Dennis have published a lot on this, and I'm going to pick up this thread when we talk about Denosumab. But in general, it seems to be true that as bone density goes up with a therapy, fracture risk goes down without a perfect correlation. In people whose bone density doesn't change, however, there is still a reduction in fracture. So when we look at these markers, particularly bone density, and you have a patient on whatever, it doesn't matter, and bone density doesn't change, it doesn't necessarily mean that the drug isn't working. Your patient may say, "Oh, doctor, my bone density hasn't changed. You put me on this drug. It's not working. I want another drug." No, you have other ways of ascertaining efficacy, but it's good to see an increase, but it isn't mandatory. Another marker you can use is bone turnover, and here's the beta CTX, an easy, commercially available marker obtained in the fasting state, and you can see in the orange how quickly and profoundly zoledronic acid reduces this beta CTX, and it keeps it down. Each of the arrows, by the way, are the yearly doses of Zol. So you keep the bone turnover marker down, and notice that with each of the arrows, you don't further reduce bone resorption. So bone resorption goes down to a level, and with repeated dosing, you basically keep it down. Now that's CTX. If you look at a bone formation marker, bone-specific alkaline phosphatase, you see a slower inhibition, which is typical, as I mentioned. This is kind of the idea. You rather quickly reduce bone resorption, and then following the linkage leads to a reduction in bone formation, but not necessarily to the same degree. But it's down for sure, and it stays down for those 36 months. If you use another bone formation marker, like the P1AP, you see, in fact, a little bit more profound reduction, but seemingly it takes a little bit longer, as you would expect. So you could, in your patients, use bone turnover markers as another way of ascertaining whether your drug is having the expected effect. So bone density, of course, is the gold standard to track patients with bone density, or you could use bone turnover. The Medicare agency will allow you to do bone density testing in the United States. I don't know how it is in Canada. Every 23 months, right? To the day. If you order a bone density test 22 months and 30 days or 29 days later, you might have trouble. There are exceptions, however. And one of them is after you start an FDA-approved treatment, you are permitted to do the bone density test 1 year later. A lot of people don't know this. They say, well, we have to wait 23 months. I never wait 23 months. It's too long to wait. I do it 1 year later, and it's okay. And even if you have trouble, you should do it anyway. You want to get an early read. The test has become so inexpensive. Patients say, you know, doctor, who's going to pay for this? If it's denied, I say, you're going to pay for it. How much am I going to have to pay? In New York, you might have to pay all of $63. Massachusetts, what is it? No, low. Do you know how much a 25-hydroxy vitamin D assay costs? Much more, $100 to $200. It's cheap. And once you tell a patient that that's all, they say, oh, do it. Okay. Now, here's an interesting parameter, height loss. And you can see that there was less height loss in the group that got Zol than the group that got placebo. So that might reflect the nature of preserving vertebral height. Now, there was another study done, very important study, to address the question of subsequent fractures after someone has a hip fracture. So this speaks to this question of a fracture begetting a fracture begetting a fracture. And this is the first study that was actually designed to determine whether or not a drug like Zol would reduce the risk of subsequent fractures after a person had sustained a hip fracture. Another big study, 2,100 patients received zoledronic acid and 1,000 received placebo. You can see the mean age. And the group that got placebo, that is an intravenous injection of nothing, could be put on another agent for osteoporosis, but not another bisphosphonate. And here are the results. Overall, the clinical fracture incidence was reduced by the group that got zoledronic acid. Clinical vertebral fracture and non-vertebral fracture incidence was reduced in those that got Zol. And there wasn't significance in terms of the subsequent risk of hip fracture. The p-value was 0.18, but there certainly was a trend, but not true significance. And then a very interesting other observation was a reduction in all-cause mortality. Very interesting. But we don't really know on the basis of that. Here are the Kaplan-Meier data showing a reduction in all-cause mortality. But it doesn't appear to be related to a reduction in hip fracture because there wasn't a significant reduction in hip fracture. But these other fractures, of course, have morbidity and they have mortality associated with it. So we don't really know. But it's of note that all-cause mortality was reduced in these people who were at high risk for a second osteoporotic fracture. Now, have you used zoledronic acid? You all have used it? What is the first thing your patients ask you? Always, always. Never ask, does this drug work? Wouldn't you think that would be the first question a patient would ask? No, it isn't. Either it's an assumption. Yeah, the doctor wouldn't prescribe a drug that doesn't work. Side effects, side effects, side effects. Okay, so here is the acute phase reaction, which has particular relevance for zoledronic acid. It can occur with the oral bisphosphonates, but it's very unusual. And here are the acute phase reactions: pyrexia, myalgia, flu-like illness, headache. It's a flu-like syndrome. And it might have something to do with the shunting of that mevalonic acid pathway and the shunting into the generation of T-cell-based cytokines. We really don't really know, but something like that is happening. And you'll notice that on the bars, the first bars for each of these items are after the first dose, and then the second and third bars reflect the second and the third dose. So you can see that if it's going to happen, it's going to happen more likely the first exposure to bisphosphonate. And by the way, if someone has been on an oral bisphosphonate, the chances of this reaction are reduced. If someone has never been exposed to a bisphosphonate, this is a greater effect. But it's somewhere between 10 and 15%. Usually it's for a day or two, although rarely a person can be really symptomatic for a week. We've seen 1 or 2 patients who have been very symptomatic for more than a day or two. And we try to prevent this by giving patients acetaminophen or Tylenol. Extra strength Tylenol, give it to them 2 or 3 times a day, the day before, the day of, and the day after. And that will reduce the risk of these events by about 50%. So it still can happen, but it will mitigate the severity and reduce the incidence. So you should talk about this. This can happen. In terms of renal safety, the clinical trial did not show any change or difference in the slight decline in creatinine clearance over the 3 years. There was no difference at all. However, there is a major concern with zoledronic acid. And as you know, the package insert contraindicates zoledronic acid when the creatinine clearance is less than 35 cc's a minute. Another point is you should take your time, as true for any intravenous administration. We give it over 30 to 45 minutes. Package insert says 15 minutes. If you send your patient to an infusion center, they will give it over 15 minutes unless you instruct otherwise. And we're in our great Columbia system. Great is in quotations, by the way, with regard to the electronic medical record and prescribing that way. You have to write a note in the EMR saying to be infused over 30 minutes, or else they'll give it over 15 minutes. But be aware of this. Be also aware that the bisphosphonates are relatively contraindicated, the oral bisphosphonates, if the clearance is less than 30 cc's a minute. Now, that doesn't mean that they're dangerous or they don't work, but the fact that the renal route is the route of clearance of these drugs, it goes to show. I mean, obviously, if the person has compromised renal function, these bisphosphonates can build up. And so there is a theoretical concern about that. But the drugs have been shown in post-hoc analyses to be effective in people who have stage 3B CKD, below 30 cc's. So you have to be careful, and I'm not saying you should use it, but you need to know about that. Now, zoledronic acid, everybody reads package inserts, you know, they're armed with information. doctor, this is going to cause a heart attack, this drug. I read about it. What they mean is that in the phase 3 trial, the adjudicated serious adverse events showed that atrial fibrillation occurred significantly more in those who got zoledronic acid, 1.3%, versus the group that got placebo, 0.4%. The incidence of atrial fib as an AE was not different. So let me make it clear what the difference is between an SAE and an AE. Do you know the difference? Okay. An SAE, serious adverse event, is an event that causes death, pretty serious. An event that causes hospitalization and is life-threatening. An event that prolongs hospitalization. Those are the definition of an SAE. What's an AE? You're in a clinical trial, and the clinical coordinator or the doctor says, how you doing? And the patient says, I'm fine. Have you had any issues since I saw you last? Oh, doctor, I had a headache last week. That's an AE. I stubbed my toe. That's an AE. I had a dizzy spell. Anything that happens, literally anything that happens negatively in a patient who's in a clinical trial is an AE. So, in a well-run clinical trial that captures all information, what do you think the incidence of AEs should be? High. 100%. 100%. And most studies indicate AE incidence in placebo and drug at least 80%, usually 90. And if it's less than that, you've got to start worrying about whether they were capturing the information. Getting back to AE, the SAE of atrial fib, does that make any sense? The drug goes to bone. It doesn't go to the heart. Why should it cause AE, atrial fib as an SAE? Well, we have no idea. And in fact, it probably doesn't. You could argue a couple of things. You could say, well, these drugs could reduce the serum calcium. We know. We use intravenous bisphosphonates for hypercalcemia. So how do we know the patients don't have an acute drop in the serum calcium and that triggers a cardiac arrhythmia? Doesn't happen. And the SAE actually happened several months after the infusion, so it can't be that. Well, we know these drugs have affinity for calcium, and we know that ectopic calcium can be organized in soft tissue and in the vasculature that begins to look like bone. It's very interesting. Amorphous calcium deposition can actually structure itself to look like bone. So maybe there are little flecks of calcium in the SA node, and the drug sees it and goes there and tweaks the SA node. These are all crazy ideas. But to think about it, but there were no issues there. There was no EKGs evidence. And furthermore, that was the only study in which atrial fibrillation was seen as an SAE in terms of zoledronic acid. And there have been many other studies. In fact, when used to prevent metastases, we use a higher dose of Zol monthly, and we've never seen atrial fibrillation. So there are lots of reasons for not considering this a major issue. But you should know about it because people will ask you, and you have to give them the evidence, okay? So let's go into a few other things. How do these drugs work over time? These clinical trials are typically 3 years. And in the old days, we didn't have a time limit. But there was a question, well, what is the evidence that these drugs actually work beyond 3 years? So the FIT trial was extended into a trial that was called FLEX. And the idea was the patients who had been in FIT, the arm that had received alendronate for 5 years were re-randomized into a placebo and then 2 alendronate arms in those days. There was daily alendronate, 5 milligrams and 10 milligrams. And this is the scheme. This was FIT. They took the alendronate arm and then re-randomized into placebo, 5 milligrams or 10. It turned out that the 5 and the 10 milligram doses gave exactly the same data. So they were collapsed. So the data are shown as re-randomization, a group that had alendronate then were off alendronate for 5 years. So it's alendronate 5 and placebo 5, or alendronate 5 and alendronate 5. So we have 10 years of alendronate or 5. And in terms of the hip density, you can see that there is in the open triangles, that's the group, closed triangles, that's the group that stopped alendronate. You see that there is a drop in bone density. Gradual over 5 years, but they're almost back to baseline. While the group that continued alendronate in red pretty much held up their bone density, but it plateaued. All these drugs, with few exceptions, which we're going to talk about, will increase bone density for a limited period of time, and then you'll see no further gain. If I had shown you the vertebral bone density, you wouldn't have seen such a dramatic fall. The vertebral bone density hangs up pretty well after you stop alendronate. There may be a little bit of a drift downward, but nothing like the change in hip density when you stop alendronate. And it may give you pause, because if you're going to stop these drugs, are you going to start to reverse the beneficial effects of the drug? Well, here are the data, looking at the 10-year experience, years 5 to 10, and in the yellow shows the group that continued to get alendronate for the entire period of time versus the group that was switched to placebo. And this relates to clinical vertebral fractures. Clinical vertebral fractures, as you know, are 1/3 of the vertebral fractures that we see, was significantly reduced in the group that continued on alendronate. So we could say that 10 years of alendronate continues to show efficacy with regard to clinical vertebral fractures. What about the other fractures? Well, the other fractures, not so. The X-ray based vertebral fractures, that is the non-clinical vert fractures, there was no difference between the group that stopped and the group that continued. And in terms of non-vert fractures, there was no difference either. So take your pick as to whether you're going to say the drug has continued benefits or no longer does it have effects after the first 3, 4, 5 years. That's where we are with alendronate. Now, one more thing. Ann Schwartz from your neck of the woods, a wonderful person, did a post hoc analysis of that data. And she did look at non-vert fractures with specific reference to T-score. And she showed that in those who had T-scores of less than -2.5, there was a significant effect of continuing alendronate in terms of reducing the incidence of non-vertebral fractures with a risk difference between the placebo and the treated of about 13%. So here again, it's post hoc. And we have to not be sure that this is really the case, but it does suggest that there might be an effect not just on clinical vertebral fractures, but also non-vert if you continue alendronate. So the long-term benefits of bisphosphonates via flex, there's maintained spine density I didn't show you, maintained hip density, 50% reduction in risk of clinical vert fractures, and a 50% reduction in the risk of non-vertebral fractures by post hoc analysis. in those whose T-scores at the femoral neck were less than minus 2.5. So a high-risk group. The high-risk group that we're going to talk about, these are the people who you might be more likely to be wanting to continue treatment. Now, the zoledronic acid study has also data with regard to additional effects after the 3 years of the clinical trial. And very similar to the FLEX trial, they took the group that got zoledronic acid and they divided that group into one that continued to get zoledronic acid, and that's described as Z6, or a group that's flipped over to placebo, and that would be Z3, P3, and as the control group. And in terms of femoral neck bone density, there was a slight drift in green in the group that stopped taking Zol after 3 years. And the difference between the two, the group that continued, the group that stopped, was small but significant. And in terms of the effects on fractures, now we're talking about morphometric vertebral fractures that did not show any major difference in terms of the alendronate experience. This is the extension study, and in fact, from this study by X-ray-based vertebral fractures, there was a continued benefit of zoledronic acid in contrast to the group that stopped. And I just show you on the left the data from the core study where there clearly was. In fact, the percent difference was a little bit greater in terms of the core study. Look at the placebo group. It's very interesting. The Z3P3 group, they had 3 years of Zol and then 3 years of no treatment. Their incidence of vert fractures was 6.2% versus the placebo group that had never received Zol, and their incidence was 10.9. So you see the effect of drug the first 3 years of drug. But if you continue drug for 3 more years, you see a even better effect. Now, clinical vertebral fractures, which were affected by prolonged alendronate, were not affected by prolonged zoledronic acid. So, you know, we've got disparate values, disparate results in terms of the where these drugs seem to be have prolonged efficacy with prolonged treatment. Non-vert fractures, here is the no difference, and there was a difference in terms of the core study. Non-vert fractures always are less dramatically affected by drugs than vertebral fractures, and we talked about why that is, because these are lower turnover sites, and you really depend on bone turnover to get drug to sites of bone remodeling. Not surprisingly, on the left, yeah, a small effect, but clinically significant, but no effect on non-vert fractures in the group that extended their Zol for 3 more years. So, for sustained efficacy at all sites, bisphosphonate therapy would have to be maintained. But adverse events related to long-term use requires qualification, and we have to have a discussion of when to stop, and if we stop, when to restart. So, on Saturday, there was a case discussion at the National Osteoporosis meeting, and I thought it'd be fun to discuss it here. So, I was the discussant of this case. The people on this panel were Bob Adler from Richmond, from the VA at Richmond, Steve Harris from, again, your neck of the woods, UCSF, and Ken Sag, who's at the University of Alabama. 75-year-old white woman treated for 5 years with alendronate because of osteoporosis, as determined by T-score of minus 3.2 in the lumbar spine, and a compression fracture at T11, which occurred while lifting a bag of groceries. I think just without any further knowledge, I think you'd be hard-pressed not to treat this woman. Her bone density at the total hip was minus 2.8, and at the femoral neck was minus 2.5. I didn't put in the distal radius because I get everybody upset and confused because everybody doesn't, nobody measures distal radius, so I didn't put distal radius in. No postmenopausal estrogens. She doesn't smoke. She doesn't drink excessively. She has a history of left breast cancer, status post bilateral mastectomies, and she never received aromatase inhibitor therapy or X-ray treatment. Okay, so 5 years of treatment, and after that, she reports and has no interval fractures. Her bone density has gotten better, lumbar spine by 6%, so her T-score is now minus 2.6. Her total hip has improved by 3% to a T-score of minus 2.5, and her femoral neck shows no change. Her bone turnover markers. Osteocalcin is 7, normal is 8 to 22 and nanograms per ml, and the CTX is 60 picograms per ml, and I gave a normal range of 150 to 450. That's reasonable. And she is concerned about the terrible side effects of bisphosphonates and wants your advice, I guess it doesn't read right, your advice about continuing or stopping. Just wanted to see where we're going here. So here is the official information about bisphosphonates, as in the package insert. There is a class warning regarding upper GI symptomatology for the oral drugs. There's a class warning about infrequent bone, joint, and/or muscle pain. We almost never see this, but for some reason the FDA reissued this warning in the number 2 bullet, despite the fact that there's been no additional information. It's very rare. The influenza-like syndrome we talked about, particularly after the first dose of IV bisphosphonate, class warning regarding osteonecrosis of the jaw, and a class warning about atypical fractures of subtroch regions of the femur. So the patient says to you, I know this causes my stomach to hurt. They cause my jaw to fall out. They cause fractures. This is what's going on here. These drugs are supposed to prevent fractures. They even cause cancer. Epidemiologically, there's some poor studies that have alleged that they're associated with esophageal cancer. And they're all the same. So, here are your choices of this patient. And we asked the audience, I'm going to write down your responses. I'm going to tell you what they said. But here are your choices. Start zoledronic acid. You're going from alendronate to Zol. Continue alendronate. Switch to Denosumab. Start teriparatide. Or you can stop. You can stop. Okay.
Is the start teriparatide adding, like combination therapy?
No,
or
no,
switching?
you stop. No, you would
Switch
stop.
to teriparatide.
You would, yes, that's a good question. No, the intention was you'd stop alendronate and start teriparatide. Not that you would add teriparatide. All right, so what do you think? Start zoledronic acid. How many takers? 0. 0 takers. Okay. Continue alendronate. No takers. Yeah, okay. This is a discussion. Yeah, maybe? Maybe. So you would continue. We have 1. 1 for B. Okay. Switch to DMAB. 1, 2, 3, 4. Okay. C is 4. D, start teriparatide, not add. 1. Okay. And stop. How many of you would stop? 1, 2, 3, 4, 5. Okay. Very interesting. Very interesting. So we had a big discussion about this, and all of us, so-called experts, voted for E. We voted for E because we thought she had done very well. She still is at risk, but she had no fractures, bone density went up. Markers are low, really low. And we know that these markers will stay down for probably a year. So she's still getting benefit, even though she's not getting continued therapy. We also thought that B was reasonable because she's still at risk. You could argue, just as we talked about, you could go for B. So we went for E, thought B was a reasonable alternative. We didn't like the idea of Zol. Why you give Zol? We didn't like the idea of switching to Denosumab. What are you gaining by that? And teriparatide, you know, nothing, she's not getting worse. You know, if she'd gotten worse, for sure, if she had had a fracture, I would, no doubt, we'd go for it. All right, so that's what our thinking was. Here's what the attendees. It's really interesting. So there were a lot of takers for switching to DMAB. I couldn't believe it. And starting teriparatide. I was very surprised by that. And only 17% wanted the drug holiday, and only 3% thought that it was reasonable to continue, which was really, you know, we had the audience response system. So we got these results immediately and then had a nice discussion about how we would deal with them. So when is it prudent to stop after continuous use? The field has acknowledged the need to consider this point by virtue of the adverse event profile. And some will stop after 3, 4, or 5. But there are situations when you wouldn't stop. Now, this isn't one of those situations, but it could be. Somebody who has had an interval fracture, continues to be at high risk. I mentioned to the audience on Saturday that I was called by a rheumatologist who was taking care of one of my patients, a man who's now pushing 80, and he's been on 16 years of continued Zoledronic. The rheumatologist said, you better go back to Dr. Bilezekian. This is ridiculous. Why is he giving you 16 continuous years? He called me very upset. The man has had a T-score of the distal radius of -6.2 for 16 years. He hasn't moved, actually. 6.2. His bone markers are not as low as this person. CTX is like 125. Osteocalcin is like 15. Low normal. So he's not super suppressed, but he's controlled. And he hasn't had any adverse events. And it's a situation where I consider to me still at high risk. Now you can say, why didn't his bone density go up? I really don't know. But it hasn't gotten worse. And it's really low. So there are situations where you are justified. But after this discussion, I said, why don't you take a year off? So anyway, there's a discussion you have to have with your patient. If you stop, you're giving your patient a holiday. That's the term. And when we use the term holiday, we mean it. A holiday is not forever. Nobody goes on permanent holiday. So when you tell your patient you're giving them a drug holiday, you're also telling them that you're going to restart at some point. Not necessarily the drug you were using, but you're going to consider retreatment after a period of time off therapy. And how long you should be off therapy is, again, a matter of judgment. Some people track the bone density, and if it starts to drift down, they'll restart. Some people will track bone turnover markers. I do. I love to track bone turnover markers, because if they start to go up, that's telling you that the effective drug is wearing off, particularly with zoledronic acid, where you could have bone turnover markers suppressed or low for 2 years. So after 1 year, if the markers are still low, I would not retreat. Most of us will actually go for about 2 years with Zol because it seems to have such a prolonged effect. On the other hand, with Risedronate, the half-life of Risedronate is much shorter, and bone turnover markers typically come back within a year. So again, some parameter you need. Obviously, if the patient has a fracture and something bad like that, you would restart. And these are the things that you have to consider. And then, a very important question. Doctor, I've been on this drug for 5 years. I'm at risk for my jaw falling apart and having a fracture. And you're going to restart drug. That means I'll be on 6 years. 5 years plus 1. And then 5 years plus 2. And so the question is, what do you say to that patient? Well, yeah, you're at further risk the more we use bisphosphonate. Or do you say, the risk of these rare side effects reverts pretty quickly within that year to whatever the baseline risk was, which is very low. So it's really not like getting your 6th year of bisphosphonate, but more like getting your 1st year as it relates to this. So do you have thoughts about that? Would you go for, you think it's, the risk goes down quickly, or it maintains itself and then you add to risk when you restart? You have thought?
I think the risk will go down with
It goes down. It goes down. It goes down rather quickly. So you can tell your patient your risk, as low as it was, is even lower having stopped the drug. Okay, so this obviously, yes?
What do you tell people when they tell you they're about to have a dental procedure of some sort?
Yeah, it's a tough one. Let me address that. So what do you tell patients when they're going to have a dental procedure? In the old days, when we first recognized osteonecrosis of the jaw, there were dentists who would call me and say, I want you to stop the bisphosphonate because she needs routine dental hygiene. Cleaning her teeth. No, you don't have to stop bisphosphonates to have your teeth cleaned. The dentists now understand that. That's not a risk. A patient who is going to have major dental work, implants, that's probably the best example. There are many reports where that is not putting the patient at added risk for ONJ, but theoretically it might. And the better part of Valor is, even though it's unlikely, we would stop for the period of the implant procedure, which can be long. It depends on what the reconstruction is, but some implant procedures can take up to 9 months. More if you have good dental hygiene, it will take 5 or 6 months. But anyway, it's a period of time. So major dental work, we stop. And don't get into an argument with the dentist, because you stop, but these drugs are still working. Then don't get, so say, okay, we'll stop and then we'll restart when everything is better. Well, it's a good question because it comes up a lot. Yeah.
Do you think, based on what Dr. Lady talked about combination therapy yesterday, Cosman said yesterday that we would be putting your case at risk by starting teriparatide because her bone density at the hip is -2.5 and it affects cortical porosity?
Oh, I see.
Think that's
No, that's ridiculous. She would say that, right? No, she would say the patient's at risk.
I think she was saying -3.5, but
Yeah.
raised the issue.
There is a temporary increase in cortical porosity with teriparatide, and it happens in cortical sites. So theoretically, the hip could be in the early going at greater risk if you start teriparatide. In this case, no. Maybe I would agree with Felicia if it's really low, probably. But there are no data here to say that fracture are enhanced when you start teriparatide. And we're going to talk about teriparatide. Actually, that cortical compartment is improved I don't know if David showed you those pictures. Pretty impressive in gain in cortical width. So I think, you know, after that short while, it reverses itself pretty quickly. All right. No drug is safe, right? Nothing you do in life is safe. You know, depending on where I am in the world, I say like crossing the street in Athens, or in Yerevan, Armenia, or in Sao Paulo, Brazil, or here at Broadway. You know, whatever you do, you're taking a risk. And you have to consider what that risk is in relationship to your desire to get across the street. That's a given. And we've talked about all of these. Now, this is ONJ. It's exposed bone in the jaw. It happens not spontaneously. It happens if there is a major event, like a tooth extraction, or someone who is terrible periodontal disease and there's already erosion. But this to happen spontaneously is very rare. What is ONJ? It's an area of exposed bone in the maxillofacial region, whereas there's no healing over 8 weeks after being recognized by a healthcare provider. Patient comes to you and says, I've had a hole in my jaw, doctor, for 8 weeks. That doesn't count. Has to be witnessed, observed, logged in. 8 weeks, no healing. And as I said before, usually it's triggered by something. Extraction, some major trauma, infection, and the like. And they aren't all symptomatic, but most of the time there is a concomitant infection. In terms of the use of the bisphosphonates for osteoporosis, which obviously is a much lower dose than we use when we are treating these drugs to prevent metastases, the incidence is really low, like 1 in 100,000 most figures are indicating. And in Germany, there was a study that indicated 1 in 250,000. While the incidence of the ONJ occurring in people who are being treated with higher doses is substantially higher. But we're talking about the side effect in people who are being treated for osteoporosis. So let me put this into context. This is a slide from Dr. Michael Lewicki, and it's really very, very helpful. This is risk per 100,000 people per year. And you start with any fragility fracture, and it's that many. Hip fracture, anaphylaxis from a penicillin shot, 32 per 100,000. Death from a motor vehicle accident, 11 per 100,000. Death by murder, not New York City, by the way, but other places in this country, 6 per 100,000. ONJ, 0.7 per 100,000, which is the same as the risk of getting hit by lightning in New Mexico. And we say New Mexico because that's the state where there's the highest incidence of lightning strikes. There's a lot of dry white lightning in New Mexico. So I tell patients, this is your risk. And it's the same as getting hit by lightning. And then I ask her, do you worry about getting hit by lightning? She said, Doctor, of course not. Ergo, why are you so concerned about ONJ?
This is for orals or IV for osteoporosis?
It doesn't matter. Nobody has any data with regard to a difference in risk. This is just overall. Now, there is clearly an association, no doubt, epidemiologically, between bisphosphonates and ONJ. But there's always some other thing happening, and it doesn't relate to the so-called suppression of bone turnover that people would say the jaw can't heal. That's why the drug has completely shut down bone remodeling. That's actually not the case. And the other experts have said, well, the bisphosphonates are going to accumulate in the jaw where there's some activity going on, and that has never been shown. There's no preferential accumulation of bisphosphonates in the jaw. So while there is an epidemiological association, there is no really clear evidence that there's causative point here. The bisphosphonates, we do not know whether bisphosphonates cause ONJ. All we can say is that they have been associated. And the American Association of Oral and Maxillofacial Surgeons said the current level of evidence does not support a cause and effect relationship between bisphosphonate exposure and osteonecrosis of the jaw. This is a statement 7 years ago. It hasn't changed. So the dentists, thank goodness, have changed their tune about the concern that they used to have. All right, let me move on to the other big elephant in the room, and that is the so-called atypical femoral fractures, AFF we call it. We used to call them subtrochanteric fractures, but they can occur anywhere from the subtroch region to the mid-shaft of the femur to the distal femur. So we call them atypical femoral shaft fractures. Elizabeth Shane, who you have met already, right? She's been with you? Who's coming? I'm sorry, I've lost my... Oh, you're going to see her in 11 o'clock. Okay. So Elizabeth has headed, she and David Burr have headed the 2 task forces of the ASBMR on atypical femoral shaft fractures. First reported about 10 years ago, clearly associated with long-term bisphosphonate use. Some additives might be, like estrogen or glucocorticoid, may be additive. By bone biopsy, these people don't appear to have double labels, but it doesn't mean these people are always suppressed. This is the picture of the atypical fracture, and you can see there's an obliqueness, sometimes it's transverse. You can see that the cortex is very thick, and there are other features. There's beaking here. There's often a prodrome of thigh pain. These people will complain of deep-seated pain. Sometimes they can identify it as bone pain. The cortical thickening happens to be a fairly noteworthy feature. And some people have alleged that the bisphosphonate is thickening the cortex. And David Dempster has said, well, if that's true, the bisphosphonates should be even better drugs than we've known them to be. The bisphosphonates do not thicken the cortex. Maybe these people already had thickened cortices. And the issue of there being a preferential disposition of Asian women versus non-Asian women might relate to a sense that the cortex in such women may be thicker to begin with. So that's a point. They're considered to be stress or insufficiency fractures. There used to be a periosteal stress reaction. Now it's less emphasized. This, by the way, is most recent update and gives some more thoughts about this. The relative risk of this condition is high relative to those who are not on bisphosphonates, but the absolute risk is low. So it's a little higher absolutely than ONJ, granted, but still very, very unusual. And as I mentioned, the risk of this, as well as ONJ, appears to decline rather rapidly after stopping bisphosphonates. And this issue of geometry, some people say that bowing, some people have more bowing of their femurs, may change the biomechanics and lead to this. Asian ethnicity may relate. Some people have said because these drugs are so good and strengthen the hip and the femoral neck, that the biomechanical stress is transferred to the leg. So actually this is a benefit of the drug. By preventing hip fractures, you have a slightly increased risk of mid-shaft fractures. These so-called atypical femoral shaft fractures can occur in people who have never been on bisphosphonates. It's not exclusively seen in people who are on bisphosphonates. So it's there, and we have to deal with it. The notion of the drug holiday then is relevant. And we individualize this discussion. Some women, particularly at lower fracture risk, may consider a drug holiday for a period of time. Those who are still at high risk, maybe you want to continue. And maybe bone turnover markers. I mean, it all depends on what you think about bone turnover markers. But they may be helpful.
If a patient is on continuous steroids or if a patient is on aromatase inhibitors, would you still consider a drug holiday? If the patient is continuously at risk.
This is the question, is an aromatase inhibitor. I'm much less likely to stop a drug, a bisphosphonate, if somebody's on an aromatase. In fact, I don't think I ever have. I have a number of patients who are on an aromatase inhibitor, and I can't remember that I've ever stopped. I will stop when they're off, but now we're using it for 10 years now instead of 5. I used to say once you get off the aromatase inhibitor, then we'll stop, particularly if they were not at high risk to begin with. But you know what happens with aromatase inhibition. You know, bone density plummets, and I don't know what would happen if I stopped, even for that year. So I'm just thinking about my patient. I haven't stopped anybody. That's a good question. Yeah.
Do you have a preferential bisphosphonate if someone is on steroids?
If someone what?
If someone is taking glucocorticoids?
No. I don't think we're going to talk. Have you had a discussion about this yet? All right. The American Rheumatology Association has confused everybody. If you've read their guidelines, you don't know what drug to use. It has to do with how long the patient is anticipated to be on prednisone or the equivalent, what their baseline risk is, how long they're going to be treated. And then they have a whole list of, well, you could use alendronate and risedronate, or maybe you should use zoledronic acid. And when they're at very high risk, you use teriparatide. But I don't think there is really good evidence one way or another. The thinking is zoledronic acid may be more efficacious, and there are some head-to-heads with terms of bone density that have suggested that. In terms of teriparatide, clearly the head-to-head with alendronate showed that teriparatide gave you better changes in bone density and a reduction in fracture risk. So there are some data to give you some clue. But there isn't any favorite bisphosphonate I would use. And you don't always use a bisphosphonate or something in someone who's going to be treated with steroids. It all depends on their baseline. So anyway, we've pretty much decided, we've talked about this. We don't have to continue the discussion. Okay? So the evidence from the trial shows that long-term treatment with bisphosphonates reduce the risk of fractures. Not all fractures, but depends on the drug. The potential for serious harms have not been shown to be real or causally related. And if real, they are uncommon to rare. And if the harms are real, the benefits far outweigh the risk for women with osteoporosis. Yeah.
So what about for the younger woman that you have on bisphosphonate that asks you about potential teratogenicity? What do you tell them?
Well, I think all these agents are class C.
Right.
So we don't know. So we try not to in younger women. We're sometimes forced because if they're on steroids and such, yeah. But teratogenicity, I don't think we say anything. What can you say? We don't know.
We say we don't know, but I'm wondering because usually we say we don't know, and it's not usually such a big issue in pediatrics. But like parents will sometimes like kick the child out of the room and ask and say, like, they've done research, we know it may be in their bones for at least 10 years and they're 15 now. What if they get pregnant and when in their mid-20s or 30s, will it affect? And we say, we don't know, there's no studies, but
I know Merck has collected anecdotally data.
Case reports of people that like didn't know they were pregnant, they got a
Yeah,
dose and they've
that's
been
right.
no effect.
That's right.
But that there are a handful of case
That's right.
reports.
Yeah, there are many more, but not reported. And but not, it's just collection of experiences. There are no signals, let's put it that way, in people who are on bisphosphonates and get pregnant. There's no data to suggest that they're at greater risk for something happening. But your question is another one. A kid who's been on bisphosphonate and then 10 years later, 20 years later gets pregnant, I don't think there's any information. If they need the drug, they need the drug. I mean, it's risk benefit. But I try to use the argument that to patients who are so concerned about these side effects, your risk of having a fracture are much, much greater than your risk of any of these things happening. And if you have a fracture, like a hip fracture, your life will be changed forever. Just put the benefits into the context of the side effect. And that first question, when they say, well, doctor, I just got a call yesterday from a patient. She was, had a long discussion with her on Monday. She needs to be treated, and she's settled on reclass. We agreed that this was the treatment for her. And I get a call. She said she read the package insert and now wants to discuss it with me. I'm happy to discuss it with her. But, it's this idea that the drug has to be completely free of any side effect, and that's never going to be the case.
Are the numbers needed to treat to have an effect between the orals and the IVs so different that you just go
No.
with IV?
I think the number needed to treat is a total artifact of our, it's a 1 over the absolute risk reduction. So that has to do with the numbers of patients you put in your trial. So risk is, I don't think number needed to treat has ever been used as an argument for using one bisphosphonate over another. So.
What about using teriparatide and ONG?
Yeah. Excuse me. There have been letters to the editor that say that O&J, when treated with teriparatide, the healing is accelerated. There have been also case reports of using teriparatide with atypical fractures. That has a little bit more plausibility, that if this is a low turnover state, teriparatide might get the system going. And there's a whole expectation that fracture healing in general might be improved by teriparatide. So that whole discussion is probably more worthy of consideration than O&J. But we wouldn't ordinarily use teriparatide. What O&J needs is a dental person. I hesitate to use the word surgeon because keep them away from the surgeons. The least intervention. Do not do big debridement. Slight, clean the area up. Use chlorhexidine washes. Keep the area clean and leave the patient alone. That's the recipe for cure of O&J. And most of the time it's cured. It's not, it's a big deal when it happens, but it is curable, but curable without a lot of intervention.
And then, what do you do with patients that had ONJ? Or atypical fractures, do you try again the bisphosphonate with them later? Or?
Yeah, that is a real problem because whether you think that's a good idea or not, is your patient going to allow you to prescribe the drug that caused O&J? It's a real problem because we're going to talk about the other classes too. They've been associated with O&J too. So you can't get out of that bind. They need to be treated, but doctor, this drug caused this problem. You're going to give it to me again? Are you nuts? So you're really stuck. You're stuck. You've got to go off that dime and propose another treatment. And here is where teriparatide, or one of the new drugs coming along, becomes attractive. I think you're going to have trouble if you. I've had patients who have told me. I've seen one case of ONJ, seen a couple with atypical fractures, and they just will tell you right off the bat, no way am I going to take that medicine again. Some of them will tell me that even though nothing's happened, you know. That's it, I'm out of here. So the bottom line, we're talking about rare events, but everybody talks about them. And, you know, these bisphosphonates are good drugs. They really are. So our challenge is to emphasize the importance of the disease, to place benefits front and center while properly and reasonably placing the matter of SAs in the right perspective. It's just being sensible, not ignoring, not denying, but just presenting the material that we know effectively. Okay, so here are some worthy papers on this whole subject. I call your attention to the bottom two. Elizabeth has published the update on AFF, and that's in the JBMR of 2 years ago, January. And then Dennis Black and Cliff Rosen have just published a really nice review on postmenopausal osteoporosis in the I think January or maybe March, I can't remember. Anyway, this year, and it does take it puts this whole issue of risks into the right context. So you might want to just refer to those papers as really current information. Did you get that? Okay. All right. Now, we're going beyond the bisphosphonates. And we're going to talk about new or newer approaches based upon advances in both cell biology. And the first is Denosumab. By the way, Elizabeth's coming at 11, so we better break, give you a 5-minute break. So we'll go for another 10, 12 minutes. Okay, so Denosumab. The drug the molecule we're concerned about is a cytokine called rank ligand. The cytokine is primarily a product of the osteocyte, but also perhaps the osteoblast. And rank ligand has effects on the osteoclast to activate the mature cell and also to stimulate the development of the progenitor cells that are going to become osteoclasts. Rank ligand binds to a receptor called rank, and that interaction leads either to the activation or further activation of the osteoclast or the development of the molecule. Now, of the cell. Now, if the human body or any organism had only rank ligand to act in the way it acts, all of us would be jellyfish, because it is a very, very powerful bone resorbing agent, the most powerful that we know. And 400 million years of development of the human and the humanoids requires a control. We could not have become what we are as human beings without this system being controlled. And it is controlled by another molecule called osteoprotogerin. And those little green dumbbells are typifying OPG. OPG is a so-called decoy receptor. What it does is circulate, as does rank ligand. And when it sees rank ligand, it binds it like a receptor. And it has great affinity. So as it binds rank ligand, it prevents rank ligand from binding to its cognate receptor rank. So the more you have OPG around, the less you're going to have an effect of rank ligand on this system. Some people believe that the balance between rank ligand and OPG is a very important molecular switch as to whether or not a person is going to be in balance, bone balance, or in negative bone balance. If there's a lot of rank ligand around, we're more likely to be in a bone resorpting state. So, knowing this, and this is how long have we known this system? Maybe 25 years. This really remarkable translation of basic knowledge into a clinical tool. And the example is Denosumab. Denosumab is a human IgG antibody to rank. So it's a little bit like OPG, if you think about it. Functionally, it's an OPG. And it's an antibody, so as an antibody is long-lived, and as the dose has been set to be effective for 6 months, it's a sub-Q treatment every 6 months, during which time Denosumab circulates, as does rank ligand, and like a little Pac-Man, it seeks and destroys all those rank ligand molecules very, very powerfully. Denosumab is a very powerful anti-resorber. The FREEDOM trial is the trial that led to the registration of Denosumab. It was a randomized placebo-controlled study, like all these. The dose chosen was based on the phase 2 trial, 60 milligrams sub-Q every 6 months for 3 years. The endpoint was new vertebral fractures, morphometric by X-ray, and secondary endpoints were non-vert fractures and hip fracture. Again, a big study for us, almost 8,000 women whose average age was 72. Their mean T-scores were, as shown here, 23% had prevalent vertebral fractures. And there was good compliance, 80% plus completed the study. And here are the data. A 68% reduction in new vertebral fractures, a 20% again, non-vert fractures, you never see the same dramatic effect, but a significant reduction in non-vert fractures, and a significant 40% reduction in hip fractures. So, this fits our criterion. We want a drug that has broad spectrum action at all sites, vert, non-vert, and hip. Now, the first 3 years is what I just showed you. The study was extended for a total of 10 years. The group that got DMAB continued on DMAB. The group that got placebo switched to Denosumab after the 3 years. So we have lost the blind, no longer a blinded study. We've lost the control. So we now have this transition. But we have really interesting data that I'm going to tell you about at 8 years from beginning and at 10 years from beginning. So here are the 8-year data with regard to the hip. And on the left, you'll see that the group that got 8 years of Denosumab in blue show continued increases in bone density. This is the first time you've seen this. All other drugs we have goes up, and after 3 or 4 years, it plateaus. The placebo group in white at 3 years was returned to, it looks like 4 years. This is the phase 2 trial. But anyway, it doesn't matter. The placebo group picks up, as you'd expect, when they're transferred to drug. On the excuse me, on the right is the distal radius. And again, this is the first time you've seen this. The distal radial bone density goes up and stays up. Not a lot, but goes up. And again, the placebo group goes down and then stabilizes. Now, I just showed you on the left. Now, what I'm showing you on the right are the data for non-vertebral fractures for the first 3 years and then for the next 5 years. And the next 5 years has only blue because we don't have a placebo control. But you see in blue a tendency for the incidence of non-vertebral fractures to continue to go down, which is really interesting. The statistics are a little bit muddy. Can't say it's statistically significantly lower at year 8 than year 4. But you definitely get the sense that it's going down. And it may speak to an interesting point, again, related to the relatively low turnover of non-vertebral bone. Maybe you need more time for a drug to act at non-vertebral sites versus vertebral sites. The bone density continues to go up, and that means that the hip T-score continues to get better. And you see this curvilinear relationship relative to the expected 1-year incidence of non-vertebral fractures. So this is kind of interpolating the data, suggesting that as bone density continues to go up, non-vertebral fractures continue to go down. And as I mentioned before, this discussion about whether an increase in bone density is related to a reduction in fracture risk is mindful of the other relationship which we believe in. This is one of the credos of our field. As bone density goes down, fracture risk goes up. So what this might mean is that this is a hysteretic relationship. That is, it's balanced. As bone density now goes up, fracture risk goes down. So the Denosumab data begins to make the argument that there is that relationship in both ways. So it's hysteretic, it's reversible, not reversible, but you can have the relationship in both ways. Now, the 10-year data are shown here. Here at lumbar spine, 10 years of Denosumab gets you a 21% increase in bone density. Do you know how much 21% is? How many T-scores are you improving by 21%? Well, probably 2, because each 10% is about a T-score. 2 T-score units. So if you're minus 3.5 and you were on 10 years of DMAB, your T-score is minus 1.5. Amazing. And look, the slope doesn't end, keeps going. And here's the placebo group. They take off, and they're going, going, going. And here's the hip, 10-year data for hip, 9%. Never see this. Never see this with bisphosphonates, or raloxifene, or estrogen, or for that matter, teriparatide. It is a very interesting observation. What could account for the unprecedented, relentless increase in bone density over a 10-year period with Denosumab? Open question. Did David Dempster talk to you about this yesterday? Because David is on this paper by Mike Ominsky. And this is my last point, and then we're going to pick this up tomorrow. I mentioned bone modeling as a phenomenon of growing people, children. Well, if you look very, very carefully at certain parts of the hip, and this is a triple label study that David was involved in, you see triple labels on quiescent surfaces. Now, this may mean because you've suppressed bone remodeling, so you can now see you've removed all the noise of bone remodeling, and you're left with surfaces that are modeling, that are putting bone down on surfaces that are not being resorbed? And is it possible that the reason why you see continued increase in bone density is because you're continuing to build bone through not a remodeling mechanism or that change in balance I mentioned before, but by specifically having an effect on bone growth. This is a hypothesis, but it's really intriguing. And tomorrow, I will tell you about some interesting ways that we can think about this. And of course, all roads lead to parathyroid hormone, right? My mother was right. You know, the first thing I said was parathyroid hormone. We're now coming back to this question. I'll just leave you with this intriguing observation from the phase 2 trial that at the dose that is used, 60 milligrams every 6 months in yellow, there's a doubling of parathyroid hormone in the body. If you measure PTH in your patients, baseline and 1 month up to 3 months later, the parathyroid hormone will have doubled. It stays up for 3 months of the 6 months of the period of DMAB administration. And we're going to talk tomorrow on how this could mechanistically explain the modeling phenomenon I just showed you and how bone density could continually accrue as an indirect effect of the secondary increase in parathyroid hormone as a function of DMAB. I can't tell you anymore because I've run out of time.